My name is Farina Hanrahan and I'm here with Dr. Gordon's team to discuss the Burton Hospitals. The group has been performing poorly in their patient satisfaction scores, and the poor performance was due to excessive waiting experienced by patients and redundant hospital operations. Treatment in the emergency department can be a positive experience with more focus on patient care, shorter wait times, and more organisational structure freeing up staff time, eliminating waste and giving greater job satisfaction. This requires the application of lean and value stream mapping to identify waste in the process. Significantly, when we look at this pie chart, we see that of the 9 processes, the wait time amounts for half of the time it takes to visit the emergency department. See here, 317 minutes in total. So the majority of the time spent waiting is between steps. The longest single wait is just prior to being discharged, with an average of 91 minutes. This is mostly due to a batch system that the doctors are using in the hospital. While some wait time is expected in all emergency departments, once the patient has been processed, it's ridiculous that they're still waiting. There is a direct correlation between how long a patient waits and their level of satisfaction. So to increase patient satisfaction, it would be necessary to have them see a doctor as soon as possible, especially considering that they're upset and it's usually quite emotional in a high-stress situation visiting the emergency department. Here we see the current state map. This is an important tool to use when we're looking at operations management, because it divides up the different types of time, so time that adds value and time that doesn't add value within the procedure. So inventory flow time and the resulting bottlenecks have to be analysed, because it's critical to determine the process's capacity, and this can save time for the entire process. We can see that the bottlenecks occur at step 9, and a dramatic improvement will be seen when this is taken away. And this graph shows us the capacity, process time, cycle time, and utilisation. As we can see, the physician movement is the steps with the highest utilisation. Bottlenecks increase inventory, as the system is blocked in the preceding steps and starved in the following steps. A lack of capacity in relation to patient flow rate is the main cause here. Cycle time can be reduced through process improvement, like eliminating waste, which we'll look at further on. In the system constraint, capacity and utilisation must balance out with cycle time to avoid patients waiting. So high utilisation in the last 2 steps shows how well the resource is being used. We must remember that this resource is a human resource, so it's probably being overworked. In these steps, capacity is doctors. So we know that we require more doctors. And also we're looking at a doctor and a half here. So it's not ideal to be looking at half a human being, because as they move between 2 different locations, they have to adapt from one environment to the next, and they also have to be called, and there's a wait period with them arriving for them to travel between the 2. It's important to consider waste. So we have discovered that there are 6 wastes here of the 7 wastes that are discussed in lean manufacturing. So we have overproduction, so undertaking activity just in case or in a batch. So this contributes to constraining steps with the patient pathway by feeding in inappropriate work like blood tests across the board, and the batching of discharge is also overproduction. Inventory. This refers to materials, but it can also be translated as the patient, holding inventory work against quality and effectiveness, making it hard to identify problems. Examples include the room for the patients where they're being held, but they could be discharged safely, and ordering excess supplies because there is no proper automated system. We have weight as a waste, so it refers to the patient or materials waiting, instead of moving at the pace of patient demand, waiting in queues, waiting for blood tests, waiting for the room to become available for the next patient. We have transportation waste. Any unnecessary movement of staff or patients is wasteful. We can't fully eliminate transport, but we can aim to reduce it over time. When process steps are located next to one another, it's easier to visualize and identify and resolve issues. So using the mobile X-ray and fixing the tube would mean that would eliminate transport waste, but also having handheld devices would minimize transportation waste as staff move around. Then we have staff movement. This is unnecessary in the majority of cases, and we'll look at that later in our sketchy diagram. But unnecessary movement in the workplace relates to layout and organization. So how far do you move to get to a computer to input discharge information if you're a doctor? How far does a nurse have to walk during the daytime from one place to another in order to deliver blood? We also have unnecessary processing, using complex computer systems to undertake simple input tasks, especially when people haven't been trained to do so. It can take hours for a patient to receive their discharge script. The task of actually supplying this takes a matter of seconds. So all of these wastes add up. This is our fishbone or cause and effect diagram, and here we identify that there were 6 different segments that led into the problem. So they were the root of the problem. So these were machines, physical layout, materials, process waste, training, and staff waste. So within staff waste, we had trivial reporting. Lack of automation meant that they had to step out in order to do this reporting. The volume of work means that they require another doctor permanently, and the bar-coded wristbands are not necessary and are not something that's usable. Training is required from the EMR system. Staff are not au fait with it, and this in turn is leading to them not spending enough time with the customer, and the customer feeling a lack of patient care. The batch dispatching, doctors need to be trained on a new automated system so that they can have individual reporting and people can get out much faster. The portable X-rays, which are not being used, require that staff have a change in how they think about this. This will require changing the status quo, so it will mean that you have to demonstrate to the individual how using this will minimize their workload. With process waste, blood taking is just not necessary more than half of the time. The trivial recording, the triage nurse, the ED nurse, and again with the physician is not necessary. And inventory issues, it's overstocked because there's no process of managing what stock is required. Materials is disorganized stockroom. They need Kanbans to flag what is required. Staff hoard and hide things in order to try and save time, and the storeroom is located far away from where it should be. In fact, it just needs to have cupboards inputted so that they can be refilled. Physical outlay. Patients should be processed through a physical space where you could see it in front of you one step at a time. Supply cupboards need to be on site in each examination room. They need handheld computers, and physicians must arrive from elsewhere in the hospital, which means they're wasting an awful lot of time. The machines, the tube for bloods is broken, the portable X-ray is not used, and there's no scheduled maintenance, which is causing a lot of problems. So we decided to select 2 of the processes out of the 9 and look at them in more depth. So the 2 processes that we decided to look at were step 5, the blood test, which we believe are not necessarily a requirement in every process, and step 9, the discharge, which is taking up the majority of wait time. We found that the unnecessary bloods waste nurses' time, and this diminishes patient care, and that patients waiting for release are very frustrated, and it means that their overall feeling about how they were treated is very negative, because this happens just prior to them leaving. So the effect on the process of these two steps is bottlenecks, overly high utilization. It's over 100 in steps 9 and 8. It leads to angry patients, which in turn leads to stressed out staff. In a work environment, there's very little job satisfaction, and it requires a high level of intellect to be either a nurse or a doctor, a lot of training, and very, very rigorous understanding of processes. So for them to have to work in a process that doesn't utilize them or utilize the space or utilize the time, it creates a lot of disorganization and a lot of disillusionment on behalf of staff. Suggestions. Well, first we looked at the analysis of step 5 and step 9. So blood's being taken just when they're required and patients being discharged immediately by the physician. So this requires some change management in the rationale that is given to blood tests being taken and flagging up issues that people might have, health issues that they might have, not necessarily what they came in for, but underlying issues. Freeing up the nurse's time creates huge savings. The savings that we have in step 5 show that based on an average nursing wage in America, these are given both when the tube was operable and when the tube is inoperable as it is currently. But basically, if the tube was operable and nurses were only taking bloods 39% of the time, based on the case study, it says that more than half, so we're taking that at 51%, don't require bloods, and that 10% don't require anything at all. So we're saying 39% of what they're currently doing in bloods would be the new norm, and that the processing time would be down to 12 minutes, which would be 7.2% of the nurse's job. And utilization would be down to 94%. So, utilization would be up to 170% from 94%. This would give an annual saving of $36,000 based on $29 an hour, which is kind of a mean number for an ED nurse in the States. The effects that these changes would have on the emergency department. Immediately it would increase patient satisfaction because it would cut down on the amount of time that they were hanging around waiting. They would be able to afford a full-time doctor who didn't have to divide his time between one place and another, which is very, very difficult for the doctor himself, besides the people who have to be calling him and waiting on his arrival. Having an automated system would greatly increase the doctor's ability to be able to input data while he's sitting there. In today's world, the fact that patients have to sit around while doctors and nurses walk back and forth to input data is crazy. Reducing the nurses' workload is very, very important because they need to be able to spend time with patients. Keeping data on patients will allow flagging of healthcare issues. It will allow analysis of how the system is working, and this can be the first step in implementing a change in the emergency department. As it progresses, they can look at reworking this again and cutting more waste from the system, but the data that's harvested will allow a much greater analysis to be done of how the system is working or how the system is not working. Location planning, forecasting, quality assurance, and customer service, these are all essential to having satisfied customers. And having satisfied customers in turn generates profit, and profit is the primary goal for business. Even if it's a not-for-profit style organisation, hospitals are public service, and that provision means that they're paid with public money. So this means that they don't kind of focus on profit and they're not orientated towards it. However, services generally have been greatly reduced due to recession, and they haven't considered operations management approach in designing processes to have them cost effective. Looking at the type of people who are drawn to work in medicine, they're qualified professional people, high level intellect, lengthy education, and often the management is not done by people who understand the medical process. If we implemented a system like they have in Finland, where you have to have a medical degree and then afterwards do an MA in management, you'd have a deeper understanding, and there's a cross-pollination of ideas, which would make a more dynamic structure. And presently, it feels more like there's a fight to be won between staff and management, that they're fundamentally opposed.